Okay, the topic is called joint line elevation after uniarthroplasty. Are there any problems? I have no conflict of interest with this topic. Unicompartment arthroplasty is alternate to the arthroplasty. The popularity rose during the late 1990s and early 2000s, and that's because of the minimally invasive surgery trend, and also because of an expanded indication. The previous recommendations, such as they will operate on a patient with higher body weight and BMI or younger patient. Some intra-articular pathology more acceptable, as well as the pre-op alignment. However, UKA has seen a rapid incline and decline during those phases as well. So if you look at the joint registry data now, you can see that there's a lot of incline in the number of percentage of UKA done per year when compared to total knee arthroplasty. But how to perform an excellent unique compartment knee arthroplasty? First is a proper patient selection. And it's been talked a lot, you need to have a high volume to get a good result with UKA, and also that's because you need precise surgical technique. So we all know that elevated joint line arthroplasty can cause a lot of problems such as instability, anterior knee pain, also stiffness and range of motion. So that it also applied to unicompartment knee arthroplasty. So if we look in this textbook by Scuderi and Trier, they said here that in theory the joint line should be restored, and assuming there's tibial cartilage thickness of 3 millimeter and 2 millimeter bone loss in the deepest portion, then a total of 5 is lost. And given the thickness of composite of 8 millimeters, so you need to resect another 3 millimeters of the deepest part of the tibial point, and some might raise a concern that that might be removing too much supporting bone. And that could also result in a newer complication that we don't see before. We can see tibial plateau collapse. You can see subsidence of the tibial component as well as a postoperative fracture. So how do we assess joint line elevation in unicompartment knee? This is a study from Japan. They were calculating joint line elevation using pre-op and post-op X-ray as well as the thickness of the polyethylene insert. The average joint line elevation in their study is about 4.4 millimeters, ranging from 2 to 7.8. And they found that the delta change of tibial femoral angle was correlated with the amount of joint line elevation. So this is how they do it. They measure the native pre-op joint line, and then they compare it with the tibial cut line and also with the thickness of the tibial implant. So this is also another study looking at the joint line elevation. In this study, also from Japan, but from different groups of investigators, they were doing 74 medial unicompartment knee arthroplasty from Zimmer. And in the study, their joint line elevation, they calculated directly from the amount of thickness of bone cut as well as the thickness of the tibial insert. So they don't use X-ray for this study. And what we found that there's delta change of hip knee angle about 5 degrees. The tibial thickness insert is about 8.5 millimeter, and there's weak correlation with the delta change of the ankle. What they found is that the medial joint line elevation is about 4.4 millimeter, and that's a moderate correlation with the hip knee ankle change. This is another one from France. The way they measure the joint line elevation is quite different because they're actually comparing it with the lateral joint line. They didn't compare it with pre-op joint line. So what they found from this study, they show that the difference of the joint space height between the prosthetic and the healthy compartment, more than 2 millimeters, will significantly affect the prosthesis survival. So for now, we know that the medial joint line elevation is common in medial fixed bearing UKA. Most studies show there's an average of 4 millimeter elevation. There's direct correlation with post-op alignment, and so far there's no standard method to quantify the amount of joint line elevation. So does the joint line elevation impact clinical outcomes? This is a study from Japan. Actually, they're the same group as the one I showed before. They found that in a study with 46 fixed-bearing UKA with a mean follow-up of about 4 years, they found mean joint line elevation of 4.9 millimeters. And what they also found that the middle joint line elevation reduced improvement of extension and flexion ankles. However, it's not correlated with postoperative extension ankle, postoperative flexion ankle, the knee society score. And what they conclude from this study is that the tibial joint line elevation more than 5 millimeters in uni should be avoided to prevent postoperative flexion contracture. Let me show you the data from our institute. So at Jula, we're concerned about the collapse or fracture of the tibia. So what we call a subchondral sparing cut. So we remove very small amount of the tibial plateau to preserve the strong subchondral bone support. So it's either between 0 or 1 millimeter below the deepest defect. So the conventional way, like they said, might have to remove about 3 millimeters. And from this X-ray, you can see that all the subchondral bone, the sclerotic part, will be all removed, and that's a concern for us. So what we usually plan, we do the cut at about the level of the subchondral bone. This is what we do during operation. So sometimes the piece of bone removed is actually very, very thin. Sometimes it's like sometimes it's like we shaving off bone, not really cutting out. So you can see it's very thin slice of the tibial cut. In one of we retrospectively look at our patient, in 66 patients with minimum 6-year follow-up. We found that most of the patients have joint line elevation of more than 4 millimeters, and the elevation is related with the pre-op deformity. So far, there's no revision to total knee arthroplasty, although there were 8 patients who we asked to come in for a polyethylene exchange because there was an increased ML laxity. Clinical data shows that there's no difference between the knee society score, range of motion, quadricep power, as well as the pain score. And with a correlation study, we found there's no correlation between the amount of joint line elevation and the knee society score, range of motion, pain score, and as well as the tibial femoral ankle change. So in conclusion, joint line elevation is common after medial uni. Even when conventional technique was used, it's directly related to post-op alignment, bone defect, and degree of deformity correction. And so far, we don't see negative impact on clinical outcome at midterm follow-up. So, and a damaged attempt to restore native joint line like the conventional technique might result in removal of strong tibial subchondral bone, leading to early collapse and as well as component subsidence and fracture. Thank you.